Okay, right now I have a very special guest for you. It's Paul Grundy, who's actually the godfather of the patient-centered medical home. And yeah, hello, Mr. Paul. Nice to meet you here in Stockholm. It's your first time here in Stockholm, right?
This is my first time in Stockholm and my third time in Sweden. It's a fantastic country and a wonderful organized city.
You were telling me here earlier about how you found Stockholm compared to other parts of Sweden. So could you share this with the audience as well?
Well, I mean, Stockholm is has a big city feel, and it's incredibly cosmopolitan. The blends on the street of people, of intermarriage, of food,
wow,
is just really fascinating. I think the national food is the shawarma. In Arabic, I think you call it a kebab house here.
Yeah.
But that and sushi.
Okay, and that tells a lot that there are lots of people from different backgrounds here in Stockholm.
Incredible blend. We had a wonderful Ethiopian dinner last night.
Wow, okay. So your nickname is the godfather of the patient-centered medical home. Could you just tell the audience a bit about that? Because some people probably don't know that.
Sure. Well, the concept of the medical home is one that comes into the literature as far back as the 1960s, and it's a home for the data. Mm-hmm. So once you have data, where does it go? Who's accountable for it? How does it get acted on? We began to look at that in the 60s, and I think probably the first group of folks who really used it were the transplant surgeons, because they had these patients who were so sick that it was absolutely important that all the data stayed in one place and was managed without being fragmented. So, for example, oftentimes in America, I'll have 5 specialists, or I say partialists, focusing on the part of the body with no adult supervision, with no coordination of care, and it's dangerous, it's toxic. So the medical home is the concept. The patient-centered medical home is a set of principles that was agreed upon between the buyers of care and the providers of care about 8 years ago. It's known as the joint principles of the patient-centered medical home. All of organized primary care agreed with the buyers of care that they would begin to change their system towards managing a population with a trusted healing relationship. Those became known as the joint principles of patient-centered medical home. And that's the standard of practice now in the Veterans Administration, Kaiser, across much of the United States. Canada, Australia is looking at it. Singapore, we kicked off our first pilot on the 22nd of August in China.
Earlier during the sessions, we were talking also a lot about patient empowerment, and lots of people see patient empowerment as a positive movement, but also having medical background, that there are people, especially in the healthcare industry, think of that as a negative movement. So what are your reflections?
Well, I think patient empowerment is incredibly important, but one needs to understand from the perspective of the patient and the doctor that when you have an engagement between a trusted healer and a patient, the patient's not a dart, right? The patient's not something you can throw and it's going to go the place you want it to go.
True.
The patient's going to fly. It's a bird. So the science of understanding what's going to be required to activate the patient, to engage the patient, for them to have the kind of empowerment with their family, with their community, to do the right thing for themselves, is incredibly important. So, for example, in Alaska, we have a Native American population that has the worst diabetic in the world, right? And the system that began to look at that and began to try to understand what does it take from the standpoint of the community to support a patient and help them to fly in the right direction. How do you get them exercising? All those kinds of questions, I think, are going to be immensely important in a world in which we expect and want the patient to be empowered. So there are three things that have to change. The practices have to redesign to manage a population, right? Not doing an episode of care. They then got to be paid to do that and stop being paid to do an episode of care. And then the third thing is the benefit redesign of how the patients are engaged has to change. So if I continue to pay $20 copay, I'm not really very incented. But if the system changes and the rewards are understood, so in one place with the University of Michigan, we're looking at empowering patients to exercise. And you give them one of these and you hook them up to a device that monitors it, and a year later 17% still use it. You take their benefits and you cut them in half, and you say if you use this, your benefits are going to be half as much. A year later 52% still use it. You take this, you offer it for free, you cut their benefits in half, and then you create a psychological program where you send a little reward message every week, you engage them with their neighbors, and a year later 87% still use it. So the science of that, right, that's what I'm talking about. Structuring how you engage the patient.
So you were saying that healthcare should be designed towards this movement of patient empowerment. That's the lesson to be learned here.
Yes, the system needs to be designed, needs to be paid, needs to be structured to empower the patient.
How do you see
to be engaged effectively? How
do you see the differences between a country like Sweden and the U.S. Because you've been here and there in terms of patient empowerment?
So I was fascinated by one community, and I forget the name of the county here in Sweden, where the postal workers, because they're like, don't have enough to do, they have between 10 and 100 hours of training, and they stop at the home of the patient, particularly the frail and elderly, and do a social check, make sure that their toenails are cut, make sure that they're engaged, their medicines are supplied. I mean, that's a dynamic change that I think could happen. Comparing America to Sweden, America is desperate, right? We have just tons of things going on. I mean, we have the extreme of probably some of the best integrated care in the world with Kaiser to absolutely fragmented. So it varies tremendously, but I see tremendous potential here in Sweden in the system that you have designed to start paying for service level.
Yeah.
If service is what you want, right? Mm-hmm. So if all of a sudden, so for example, I was talking to somebody where there's a 20-week waiting list for certain procedures, right? True. What if you turned that on its head, and what if you said to the system, you get more if you see the patient the first week, and then if you see that the 20th week, right? I mean, think differently, right? And I think you have the potential of doing that.
Great. Okay, thanks a lot for your time.
Thank you very much.
Hope you enjoy Stockholm and the conference as well.
Thank you very much.
Thanks a lot. Thank you. Bye.